as all speakers. But let's start with reintroductions. I can introduce you as well, but it's always better if panelists introduce themselves.
Okay, hi, I'm Sarah Williams. I'm a statistician and I work for Roche Products Limited. I also, as well as having my stats head on, I'm part of the Women's Health Research and Development Group at Roche.
Hi there, I'm Michelle Griffin. I'm a clinician by background, a OBGYN, and I now work fully in medtech, working with women's health companies that are looking to try and build out their clinical commercial strategy. So they're really wanting to grow into this space, understand what's going on, and I can help you there with my background and expertise.
Thank you. Angela Spatharou. I lead IBM's healthcare and life sciences team for Europe, Middle East and Africa. I've been with IBM for a couple of years. Before that I was with McKinsey & Company in healthcare consulting again, and I had the opportunity to work with multiple health systems globally, doing at some point some very interesting work, I think, on maternal mortality and Millennium Development Goals in Mexico and Latin America, collaborating with UN Women and the Gates Foundation and others. So very excited to be here and be part of this discussion. Thank you.
Hello everyone, pleasure to be here. I'm Marinova. I come from an academic background. I entered women's health in my PhD, which was in reproductive biology and aging. And currently I'm working with AthenaDAO, Science and Dealflow, and we try to fund women's health research through Web3 blockchain technology.
Thank you so much, ladies. Question number one. How can we really ensure that scientific research really adequately represents female population when it comes to data, when it comes to inclusion? There has been a lot of conversation about this lately. It's nothing new. It's a widely known fact that women haven't been included in clinical trials and clinical research enough. What are some biases that companies still are facing, or that you are seeing in the ecosystem, and how can we overcome that? And then consequentially, obviously, include more women in the research.
Is it on? Hello?
Yeah, sure.
So, like you... Hello?
Let's share one. Share your story.
So like you say, the first thing is making sure that they're included in research and in clinical trials. I think there's quite a few obstacles there. The first is getting women access to their healthcare systems. So, and that can be individual to countries, regions, towns. So you need, personalised might not be the right word, but you need different solutions depending on where in the world the women are. And then with my analysis hat on, is when we have the data that includes women, is actually analysing the data by sex and making sure that that's published and available publicly, so that then all scientists and researchers can make use of that information to hopefully improve women's and men's health in the future. Is there anyone that?
Yeah, I think that, like, as you said, it's really important that women are included in trials. We can all agree that. We know that's been a very recent thing, really. I think the question really is about how do we go about doing that? And probably looking at principles there. Do we do it with a carrot or do we do it with a stick? I think probably carrots work best, but in healthcare, sticks seem to be the most popular. And an example of perhaps what we could do is we say that we make it mandatory. So something such as ethics in clinical trials, to get it signed off, you're going to have a certain quota of women in that trial. But I think that we know that quotas have limitations and there are difficulties with that. I think it's probably understanding why women aren't recruiting into trials, but probably more so looking at the data. It's retention, from what I see, is harder, so that even when women do go into a trial, they're unable to stay on. And it's a question of what's going on as to why they're not staying, and how can the people running trials, the companies, organisations, etc., look to enable higher retention rates. And I think the latest data coming from decentralised trial platforms is showing that actually, potentially with digital platforms, things being more accessible, a more flexible approach is only going to be a good thing with regard to recruitment and retention of women.
Thank you. I just wanted to add a slightly different angle to this, which is differential treatment and outcomes when it comes to healthcare delivery. So when I worked in the US, I remember reading a very interesting study that in some cases they had identified there were differential outcomes in cardiovascular disease of women who had serious issues in cardiovascular health compared to men of the same cohort, because in some cases there was an implicit bias that women would present with some malaise. They probably didn't speak the same language or express their symptoms in the same way, and they were considered someone who suffered from anxiety or depression, and literally in some cases prescribed antidepressives, while in fact there was a lurking physical health issue that had not been identified. So I think one of the things that the health system would find helpful would be to actively call the situations, identify the biases, and educate people. We've addressed biases in other areas, why not in this one as well?
I definitely agree, and even before clinical trials, I think we also need to pay attention to research studies and to include both sexes there, because we do have research gaps, data gaps there as well. And female animals are being excluded from studies because it complicates the study design so much. It introduces more variability, it makes analysis much more complicated, which requires higher budget for studies to include both sexes and then the other analysis. So we do need to convince regulators that it is actually necessary, even though it is expensive and it is more complicated, and that it's worth doing. So there are standards put in place that regulate these things for governments, for grant institutions, as well as in the publishing industry.
I want to. Oh, are we run out of battery on this one? Hello? Yeah? Yes, we did. All right, we'll speak a bit louder. I want to mention something in this context that that I've discovered in writing my articles for Forbes, is that we really have to differentiate between conditions that affect women predominantly, let's say, or only, like endometriosis or females, and we have to differentiate between conditions that affect both men and women, but women are not recruited enough, because in first case, women obviously will be recruited to clinical trials overwhelmingly. But the question there for me, which I've encountered in my work as a journalist and a community builder and in many different other roles, is that pharma sometimes and other organizations are not recruiting diverse enough. So very often this has been used as, excuse has been used that it's very hard to find women from different backgrounds, they don't want to participate, it's too expensive, things like that. And then secondly, what Angela mentioned was that we have to think about the biases that we have and how do we overcome them, and what we don't know, because in many clinical trials what I've realized is that we enter with this assumption that something will happen, or we have this assumption that this disease or this illness will cause this and that, but then actually turns out completely differently. I read about a clinical trial recently where it was highlighted that a certain drug wasn't very effective on white women, but actually it was proven it was very effective on black women. So I think that would be a very interesting angle to cover in the future on different events, and I'll try to cover it as well, is how do we approach it from that angle of bias, and when we get into the arena of all the different diseases that affect women, how do we approach it there? What role, when I mentioned pharma companies, what role do they play? Because pharma companies hold the budgets, they have massive amount of money, but how is it possible that in 2023 we still haven't seen, for example, enough knowledge and data when it comes to some very rare diseases that still affect millions and millions of women worldwide? How is that possible? Why is that? Or any other organization? Maybe Angela, because maybe.
Oh, well, we don't have that.
Yeah,
okay,
we don't
yes. Well, I mean, I think Sarah probably will bring more of a perspective on the inside workings of pharma. But what I know, at least, is, as I said, I was with McKinsey before, and I read a report in the last couple of years that they did that said that not more than 1% of global R&D spending in pharma was going towards women-related conditions and products, which is fascinating. Not more than 1% compared to being 50% of the population. So not only we are 50% of the population, but we also make most of the buying decisions on a family health and other basis. I think companies are starting to wake up to that idea. There's been a lot of actually very smart women in investment convincing other investors to look at things in a different way, sometimes changing the language around how they talk about the different conditions and portraying them in ways that male colleagues might affiliate more a little bit more. But it is changing. So we know that Merck spun off Omicron, which is their unit specifically for women-related products. We know there's been some interesting work from AbbVie. There's several companies right now that invest in that space. Fundamentally, big pharma, ultimately, people, to call it as it is, are interested in blockbusters, right? So they're interested in things they can sell in the order of 1 billion or more. I think it's our job to show that that market is somewhere in there. So maybe there's some work that needs to be done, maybe through advocacy, maybe through awareness that says, if 50% of the population is likely to go through these stages, menopause being one of them, for example, and face these issues, then if payers, if insurers, if buyers of health products and services commit to buying these products, pharmaceutical firms, I think, will find it more exciting. That's, again, me playing devil's advocate here, but I think there is a market there. We just haven't made the case.
Yeah, I agree. I think funding is absolutely fundamental here. I think the other thing that goes hand in hand with funding that's maybe a little bit more nuanced is the status that sits around women's health and health of women.
Yeah.
And I think, to kind of paint it in the best light historically, and we're very much looking at the future, we could say that it was because we had assumed that female bodies would behave biologically, physiologically in the same way that male bodies did. And we recognized that this was a completely flawed assumption. And whether that would be clinically, from an R&D point of view, many other different perspectives, we now know that that is flawed, and we're trying to kind of go back and pick up the pieces and rework it and actually get that basic science understanding, which really will be the ramp to accelerate off, and everything else will hopefully come. But I think what has happened is that we're missing this sort of magic status that comes around women's health, that isn't just around that the funding's there and we want to know about it. It's because we have been in a place that, even as a gynecologist, I didn't recognise how biased I was clinically and how I were viewing things, and now I'm going back round and reflecting how I used to practice and realised there were things that I just took as read when in fact I didn't really necessarily have the evidence. That's just culturally how we did it, that was how we learned to do it, that's how we were trained. So I think we need to kind of reawaken and go, wow, actually really understanding the ovaries, not purely from ovulation, fertility point of view, but from a fully hormonal, the impact across the whole body biologically point of view. This is a whole piece of science that we are just, starting around the edges. We don't have that sewn up by any means. And this is a really exciting opportunity, and we need to push that agenda far more, along with funding, of course, because they go hand in hand.
If I'm understanding correctly, we have to address it on micro level. So
We have to look at the basic science, I would say. That really is, what accelerates it, because we can then go back to the principles, the knowledge, the understanding of this is what we believe is happening. From there, we can then go, what's going on in what we see currently as disease states? Are they disease states, or is it a spectrum of normality? Is there a reason behind why this is happening or that's not happening? And where do we go then from drug development and various other management development with regard to health, but also science in total?
And Michelle, probably best example here is menopause, right? I read the other day a really interesting article. Why are we treating menopause as a disease? Menopause is not a disease. It doesn't need a cure. It's a natural state for women. All women who menstruate will go through menopause. Not all women will go through pregnancy, but precisely because we don't know much about it, we are treating it as a disease, right?
Yeah, I feel sorry. I'm just saying. I feel it's become quite black and white, this issue currently, of like you know, for ages it's been ignored. We can't talk about it. It's a taboo topic. Probably most of us here have mothers who didn't talk about it. We weren't aware of it, and then suddenly we're in a situation where we're talking about it. But the only way that we can kind of pigeonhole it, because we don't feel comfortable without being able to address it in some sort of framework, is we're going to have to call it a condition. We're going to have to call it a disease, because then it will get status, and then people will be interested, people will fund it, and then everyone's like, oh, I'm not actually sure it is a disease, can we just and because it's very new, because we don't have the similar phases of life in males, which is where the basis default sits. And so, you know, it's a whole new way of thinking about science and medicine, and that's why I think we can't jump into something further down the line of looking at treatment or management when we don't really understand the basics. What is, you know, as one of the handful of animal species that go through menopause, why is that happening? And, you know, as fertility rates, you know, age of first time conception, we're getting older, evolutionary, biologically, our menopause average age is not changing. I'm fascinated. What is going on here? You know, and we have to address these issues, and we have to understand it, which takes us right back to, do we actually even understand really what's going on with the ovary? How does puberty get triggered? How does menopause get triggered? These are all these unknowns, and I just think we really are building some momentum, as I've said to lots of people in the room today, but we need to push that more so that people are hearing, like, we need to look into this. This is exciting. This is revolutionary.
Sarah?
So I won't follow on that. I'll go back to the original question. So I can talk to Roche. There's a big, massive movement going on. We have a new CEO, Teresa Graham, who is a huge advocate for women's health and is making it a priority. And it's becoming a priority in many areas. So treating diseases that affect women only, like the endometriosis and fibroids and stuff, is one angle. The second is making sure that we embed sex considerations from the beginning of drug development, so preclinical, in cells, in animals, all the way through to our big trials at the end. Making sure that women get access to the treatments when we've got them, it's a big priority. And then rare diseases, I think I don't want to speak out of turn, but it could well be a funding issue. So there might need to be sort of incentives or like a carrot from the governments and the regulators that approve our medicines for us to be able to look into those rare diseases. I know the staff, the employees, we always want the best for patients. So, but there has to be
someone to connecting the dots, right?
Yes, yeah.
Marija, do you have something to add on this?
So the question was about pharma. I think it would be great if we are able to see some collaboration or relationship established between big pharma and academic institutions, because what we are missing is the basic research, and we can't really progress without it. It's the basis of...
I would say that one of the biggest challenges that I've seen in the ecosystem is definitely how do we include all the key stakeholders to work together collaboratively. I think it's super important to, and in a new ecosystem like women's health, for really all the key stakeholders to be included. Patients as well. I'm somehow under the impression that although everything that we do is focused on the end person, who is the patient, we don't include enough patients in these conversations. And I've seen this numerous times when it comes to, you know, startups building their products, drug being developed. I could probably give many examples. Would you agree?
Yeah, if I may say something here, I mentioned in passing some of the work I did in Mexico on maternal mortality rates, and what was absolutely striking as an example there, before we did user-based research and created the focus groups and had these discussions, there was a prevailing impression that the maternal mortality rate and aggregate numbers level was teenage girls. That teenage girls were getting pregnant and it didn't work out, and that happened. We actually found out it was women in their mid-30s, in some cases with multiple children, but who were working hand to mouth, had no time to go and get checked. So it was a totally different demographics. So left to our own devices, the system would have developed a set of interventions for the absolutely wrong age group. Not that teenage girls didn't have an issue, but the bigger one comparatively was actually the mid-30s who didn't have the chance to get checked because they were so detached from the health system.
And that's also one of the reasons that I've seen in many cases, you know, women, to your point, I think, Michelle, not being included enough in clinical trial because women are busy, they are primary caregivers, you know, you skip your appointments to a gynecologist, you know, I don't have a time to participate in some kind of clinical trial for 6 months and be, you know, measuring something 3 times per day when I have all these other things to do in my life, right? And that could be also the reason. Sometimes we cannot place all the guilt, so to say, on those who conduct clinical trials or pharmas. We have to, you know, part of responsibility, unfortunately, societal responsibility is on women themselves, but it's not because they don't want to, it's because they just cannot, because we are sometimes so stretched that it's the last thing on our minds.
And I think on that, about thinking about society overall, thank you, yep, that's good. Thinking about society overall and also really focusing in on healthcare professionals, I think it's a theme that comes up time and time again, where women don't feel that they've been listened to, or they're not actually even accessing healthcare because they don't believe it's a problem, they feel it's normal for them. I think there's a really interesting study where they looked at in urinary incontinence in women versus males. We know that incontinence is far higher, far more prevalent in women than males. And yet, quality of life scores and expectations were completely off the scale in males. It's like, what on earth is happening to me? This is completely abnormal and I need something straight away. When they looked at the females, where the prevalence was much higher, so you would expect on average those quality of life scores would be much worse because the prevalence was higher. Collectively, it was like, no, this is just normal. This is what I expect. This is what I get told, whether it's from friends or parents or a healthcare professional. And I think it's, you know, it's two sides of the same coin, as we say. On one hand, we're talking about not everything needs to be pigeonholed to be a disease such as menopause, but on the other hand, we're really trying to empower women to say, you know, you shouldn't expect this, you shouldn't accept it. You may expect it, it may be common, but you shouldn't accept it. And I think that's really important. And I think looking at the future generation, you know, with wearables, when we think of medical devices, tracking being far more empowered, they hopefully will be a generation who has far lower tolerance levels with regard to their own health.
Thank you. I know we're close to time, so I just want to say it's not all bleak. One of the things that we can bank on right now is coming back to the role of data, technology, analytics. There is a huge trend in healthcare and life sciences towards personalization. If we're personalizing, goes without saying, we will address women's specific priorities and concerns, and in the right segments, whether it is by race, whether it is by orientation, whether it's by whatever it is. So I think there is an enormous potential out there in the science, technology, innovation that is out there. Where I think we're lacking, and where I would double down, is raising awareness, and raising awareness in all of us. So you mentioned, there's one of the questions that we're discussing, it was how can we make sure there are more women in positions of leadership to help with these areas. And the truth is, there are actually quite a few women in positions of leadership. I was at a big IBM training last week. It's a technology firm. 30% of the top people in the room were women. But not everybody knows the topics. So raising awareness and doing more advocacy and using more creatively the assets that are out there, I think would go a long way.
Sorry, you guys.
Let's just touch up briefly about the role of technology. I know that everyone's talking about AI these days and machine learning. A lot of these are very early stage. We don't know the basics yet. We don't know how it will affect our everyday life, let alone women's health. And what would you maybe, mention some really good examples of how technology can be used? I just mentioned someone here. Apple has a really great ongoing women's health study now. They're analyzing data from their smartwatches, and they started with menstruation first, but then they started spreading the research, so to say, because they realized, well, actually, we cannot see our periods, women's periods in a silo. They affect so many other things. So let's make it a bit broader to hormone health. So I think that's a really great example because we see that industry giants like Apple are also realizing, well, with what we do, we should be putting more attention to women's health and female population in general, because we are missing out a really big business opportunity for addressing women. And again, through health, there's a really good chance of engaging women in these conversations. They're all technology.
Well, I think I'll have to repeat slightly what I said, but in my field, it does come down to user-based research, and the user can be any user, any segment. So I think making sure that women as user groups are included in the right ways, and then within the women broader group, which is 50% of the population, you get the subgroups in the right way, I think there is a big opportunity. To give you an example, in the UK right now, there is a lot of work around creating integrated data platforms to be used for what we call population health. Sorry, am I too close to this? Okay. For population health. And that typically would look at, let's say you're a GP and you have 2,000 registered people in your list, out of which, for example, 10% have diabetes. Further out? Do not use it. Oh, right, okay.
It's okay.
So you typically would look at a cohort based on a disease. That would be a mixed cohort, men, women, different ethnic backgrounds, but then you would say, okay, 10%, for example, could have diabetes in that cohort, and then how do I address them? We are now able to go to much further levels of personalization and get the diabetic woman with a second child who is overweight and of Bangladeshi origin into our hamlets. We can get to that level. So we just need to work together with the payers, with the system to get to that level, because the technology and the know-how is there. So I think it's a very exciting time, and we just need to keep moving forward.
Just, if I can add to that, is that, as you say, the technology is there, and the key component of that is getting the data. And going back to your original point around that women typically are the kind of chief medical officer for themselves and for their family. And so if you look at apps, not even just in women's health or healthcare overall, just generally consumer apps, it's always got a slant towards women. It's more popular with women. Women are filling in the feedback forms, they are giving the data, they are being part of it. And so you're really trying to engage with a group who want to engage, who already are engaging. And what's so key with AI is having the data, the training data that sits behind the development of the algorithms. Without that, it doesn't matter what you're looking at with generative AI, LMMs or whatever, you need that training data. And we do have vast amounts of it. It may not sit in that traditional medical setting of a healthcare patient record, but it is definitely sitting out there. And I think with the explosion of so many direct-to-consumer apps with a lot of symptom tracking, a lot of quality of life or how are you feeling surveys, even with emojis, and you're tapping it every day, not only just on gynae health, but mental health, etc. This can really give us such a rich data set to run off these fantastic AI.
And I think that those data sets can also be used to help get inclusive populations into clinical trials. So we can use the data you've just described to see, right, in this area where this hospital is, these are the issues that patients have to come to the hospital, or the diseases they have, or the minorities we have. Let's target them so that they can be included in research, and we can find healthcare solutions for them.
It was really interesting hearing you guys talk about, because a lot of what we discuss research, these things sound like long-term agendas, how governments do incentivize companies to do large-scale research. And you're right, a lot of data is out in the consumer space. How do we think about getting startups to contribute to a wider data understanding? What does that even look like, rather than these siloed databases that they are paid to build on? What does that conversation need to look like?
Well, from my experience of working with a number of startups in women's health, I think actually they're pretty data literate and they understand the potential of their data. They see it as definitely part of their assets. And they are super keen to get that out and collaborate in form partnerships. I think it's not so much on the startup space, I think it's about the adoption and use. So it's basically people with the resources, time and money that can actually say, look, this is the sort of data set that I am looking for. Now that may or may not be the NHS or in that kind of public space, But I think people like IBM and Roche would be loving to have this data, and I know that's very much, I definitely know with Roche that's what they are looking at with regard to getting that data. So I think that's something that very much can be done in the startup space, and I think it's a really good play, and I think that generally consumers are not tired. I don't know when that will happen, I imagine it will, but they are not tired. Definitely women talking about their health, I haven't seen that drop off. People want to commit to things, people want to be giving their data, and so I would just say let's maximise it. But for the startups, to be fair, they need to see that there is a path that that can go to, and I think we haven't clarified that well enough yet, for sure.
And it's also, I would say, the funding, to conduct a clinical trial when it comes to startups, they need to get funding for that. And I know a lot of startups that have done that. Maybe it's sometimes slightly easier to do that in the US rather than Europe and UK, but it's definitely changing. I think, as Michelle said, startups do understand the value of data because they know that that's something that sells to investors, that sells to consumers as well. Yes.
What do you see the impact of politics, especially with respect to reproductive health, with respect to reproductive health data? Do you find that that's going to be a challenge in terms of the accuracy of the data or even the ability to obtain it?
That can be answered differently in different countries.
I was going to say which market.
because
I
so I worked in the US and I worked in other places. If I speak about continental Europe and the UK for a minute, I don't think there's a differential treatment of that data here or any particular restrictions related to that. But there hasn't always been the interest to collect all the data we'd want to see. So there is a case to be made around what use cases, what are we actually trying to see through the data, what data gaps do we have, and then go back and collect that data. But I think one of the things that you hinted at as well is in this country and in other parts of Europe, they are putting together effectively federating data across the country that will allow, for example, startups to come in and get, for instance, anonymized data for a particular cohort and analyze it. So there's a lot of potential to do stuff if we can find the route to market.
I would like to say in an ideal world, thinking about the future, where we should be for any data, whether it's in women's health or not, but especially in women's health, is that the sensitivities, rightly or wrongly, should not be around data collection. Data should be collected. If we're doing something, we should be collecting the data. It comes to the analysis that's going to be put on. So then it's a question of who are you and what data are you asking for and what's your use cases for this data. So if you are somebody who is looking at your federal law around period tracking, abortions, etc., that's completely different to somebody else who's come to look at that same data set but has a completely different use. They want to look at, average age of change in periods related to perimenopause because they're looking at it from a drug interaction point of view, for example. The onus shouldn't be on the data collectors. It should be around the release of the data with regard to those who are wanting to do the analysis.
I don't want to belabor this, but I guess what I'm saying, to be more clear, is that individuals themselves are no longer giving that data because it's no longer protected. So how do you deal with that?
I don't think, from my experience, I think that is very US-centric rather than, as you say, it's not happened. It hasn't rippled over to the UK and Europe. But there's very different data governance, ruling around it, and there's different ramifications.
But in the UK and in Europe, broadly speaking, data is protected as data. It's not protected by condition or by. So there's a slightly different, slightly different politics, I think.
Maybe there. GDPR and similar policies.
Yeah.